Welcome to Cardiovascular and Peripheral Vascular Assessment. This will be chapters 20 and 21 in your text. These are the objectives for this presentation. In the notes section, you'll also find a video. It's a YouTube video of your heart pumping. It's about 2 minutes long, but it's an informational video and will help you to understand cardiac output. The heart has 4 chambers. The 4 chambers are separated by swinging door-like structures called valves. The main purpose of valves is to prevent the backflow of blood. These valves are unidirectional. They only open one way. They open and close passively in response to the pressure gradients in the moving blood. So the heart is a 4-chambered hollow muscular organ that's about the size of a fist. It lies within our thorax in the mediastinal space that separates the right and left pleural cavities. The heart is composed of 3 layers. You have a thin inner lining called the endocardium, a layer of muscle called the myocardium, an outer layer called the epicardium, and then you have a fibrous sac called the pericardium that covers the heart. The pericardium consists of 2 layers. You have the inner layer that's called the visceral layer, and then you have the outer layer that's the parietal layer. Then you have a small amount of pericardial fluid that lubricates the space between the pericardial layers. That's called the pericardial space, and it prevents friction between the surfaces as the heart contracts. Your left ventricular wall is 2 to 3 times thicker than the right. The blood flow to the heart is very important. Go ahead and memorize the path the blood takes to get to the important parts of the body. This will help you as we start to discuss the different types of disorders, and as you get to each of your med-surg courses, you'll learn the different problems as we see problems with oxygenation, and so it's very important to know how that blood flows through the heart. We have 4 valves. The 4 valves of the heart keep the blood flowing in the forward direction. So you have your tricuspid and mitral valves. These are called your atrioventricular valves. And then you have your aortic and pulmonic valves, and they're called semilunar valves. And they prevent blood from regurgitating back into the ventricles at the end of each ventricular contraction. We call these semilunar valves because their leaflets are shaped like a half moon, which might be helpful to remember. As you look at the diagram on the screen, you can see the right side is unoxygenated blood. The superior and inferior vena cava, blood comes to the right atrium, then it goes to the tricuspid valve, to the right ventricle, to the pulmonic valve, and then to the pulmonary artery, to the lungs. And then on the left side, you have oxygenated valve, and it's color-coded, so unoxygenated is blue, oxygenated is red. So for the oxygenated blood, it goes through and it gets oxygen, and then the heart sends it back to the body. So our pulmonary veins to the left atrium, to the mitral valve, to the left ventricle, to the aortic valve, to systemic circulation. And this is the only time in our whole body that a vein will carry oxygenated blood, is when it leaves the left side, or when it leaves the left side of the heart and it carries it to the atrium. We've mentioned our heart chambers and valves, but we'll go over that again. There are 4 valves in the heart. We have 2 atrioventricular valves that separate the atria and the ventricles. The right AV valve is our tricuspid valve, and the left AV valve is the bicuspid or the mitral valve. The valve's thin leaflets are anchored by collagenous fibers, the chordae tendineae. And then you have your AV valves that open during the heart's filling phase, that's called diastole, to allow the ventriculars to fill with blood. During the pumping phase, or systole, the AV valve closes to prevent regurgitation of the blood back up to the atria. Then you have your semilunar valves, and each valve has 3 cusps, look like a half moon. The semilunar valves are your pulmonic valve in the right side of the heart and your aortic valve in the left side of the heart. And they open during pumping, or systole, and this is when the blood ejects from the heart. There are no valves between the vena cava and the right atrium, or between the pulmonary veins and the left atrium. So abnormally high pressure on the left side of the heart gives someone symptoms of high venous congestion, and high pressure on the right side of the heart may show distended neck veins and distended abdomen. So that's why it's important to understand the blood flow to the heart and your different structures, because depending on your signs and symptoms, that will give you an idea of what's going on with your patient. The heart serves as a pump that generates varying pressures as its chambers contract and relax. Systole is the period of ventricular contraction. Diastole is the period of ventricular relaxation. During systole, the aortic valve is open, allowing ejection of blood from the left ventricle into the aorta. The mitral valve is closed, preventing blood from regurgitating back into the left atrium. In contrast, during diastole, the aortic valve is closed, preventing regurgitation of blood from the aorta back into the left ventricle. The mitral valve is open, allowing blood to flow from the left atrium into the relaxed left ventricle. This is called the cardiac cycle. During auscultation, the first and second heart sounds define the duration of the systole and diastole. So during diastole, the pressure in the blood-filled left atrium slightly exceeds that in the relaxed left ventricle. The blood flows from the left atrium to the left ventricle across the open mitral valve, just before the onset of ventricular systole. Atrial contraction produces a slight pressure rise in both chambers. And then during systole, the left ventricle starts to contract, and the ventricle pressure rapidly exceeds the left atrial pressure, thus shutting the mitral valve. The closure of the mitral valve produces the first heart sound. This is what we call the S1. As the left ventricular pressure continues to rise, it quickly exceeds the pressure in the aorta, and it forces the aortic valve open. In some pathologic conditions, the opening of this aortic valve is accompanied by an early systolic ejection sound. Normally, maximal left ventricular pressure corresponds to systolic blood pressure, which is our top number of our blood pressure. As the left ventricle ejects most of the blood, the ventricular pressure begins to fall. When the left ventricle pressure drops below the aortic pressure, the aortic valve shuts, and then the aortic valve closure produces the second heart sound, which we call S2. And then another diastole begins. Again, that's what we call a cardiac cycle. We discussed hearing our S1 and S2 sounds, and sometimes we may hear extra heart sounds. After that mitral valve opens, there's a period of rapid ventricular filling as the blood flows early in diastole from left atrium to left ventricle. In children and young adults, a third heart sound called the S3 may arise from rapid deceleration of the column of blood against the ventricular wall. In older adults, the S3, sometimes termed as an S3 gallop, usually indicates a pathologic change in ventricular compliance. And then finally, although not heard very often in normal healthy adults, a fourth heart sound, S4, marks atrial contraction. It immediately precedes S1 of the next beat and also reflects a pathological change in ventricular compliance. Heart murmurs are distinguishable from heart sounds by their longer duration. They are attributed to turbulent blood flow. They might be innocent, as with flow murmurs of young adults, or they could mean some type of problem. So there is a link in the notes section of the PowerPoint that you can go to hear what a murmur may sound like, but you want to make sure that you practice makes perfect. So you may not be able to identify these right away, but the more that you listen, the better you will. To identify these murmurs accurately, you want to learn to assess the chest wall location, where they're best heard, and what qualities you might hear. So these usually sound like gentle blowing, swishing sound. They're, like we said, created by turbulent blood flow. Things that may result in a murmur. So thickness of our blood, how fast the blood's flowing, structural deficits in our valves. Those are all things that may potentially cause a murmur. So the locations on our chest wall where you hear your heart sounds and murmurs help to identify the valve or chamber where they originate. So sounds or murmurs that arise from the mitral valve are best heard at or around the cardiac apex. Those originating in the tricuspid valve are heard best at or near the lower left sternal border. Murmurs arising from the pulmonic valve are usually heard best in the second and third left inner spaces close to the sternum. And sometimes you may have an overlap for these when listening. On the screen, you'll see some common sites for palpating arteries. In your book, there is a figure that will help you with this. You will also notice that each one you will be practicing in lab as well, so that you can practice being able to hear. Now these may change based on age. You may be able to hear it more or hear it less depending on the age of your patient. If you completed an assessment on the cardiovascular system, you also want to make sure that you understand about development. Pregnant women has an increase in blood volume by 30 to 40% during pregnancy. And this is because of the extra that the baby is putting on the mom. And then in infants and children, the fetal heartbeat begins after 3 weeks gestation. An aging adult, this is the patient that you're going to mostly see probably in clinical, and unless you work in specialty areas, your older patient is a patient that you'll probably become more familiar with, as you will see them in all areas of your nursing practice. We know that as we look at our cardiovascular system and the aging adult, the things that happen are closely related to the choices they make about lifestyle, habits, and other diseases that they might have. So we want to do some risk factor modifications. Cardiovascular disease is the leading cause of death for both men and women. So we want to look at primary and secondary prevention. So with primary prevention, these are our, going out there and exercising, eating better, not smoking, not drinking alcohol. We also want our patient, if we have secondary prevention, these are our screenings. These are going to get the blood pressure checked on a regular basis, going to health fairs, getting those screenings done with our doctor. So education and counseling will help our patients maintain our optimal level of blood pressure, cholesterol, weight, exercise, and hopefully decrease those risk factors for cardiovascular disease and stroke. There are age-related changes that occur. The risk for cardiovascular disease does increase with age. Coronary artery disease happens when we have what's called atherosclerosis, or the buildup of plaque in our vessels. Coronary or cardiovascular disease, like we said, is the leading cause of death in adults over the age of 65, and we want our patients to change their lifestyle and make better decisions. We have a decreased elasticity of the heart that affects that muscle's ability to stretch and contract. The heart valves, they become thick and stiff, and then we get a lot of cholesterol that accumulates. The patient might have murmurs. They also will have regurgitation or stenosis. The number of pacemakers cells decrease in the heart. Then the patient potentially starts to have dysrhythmias and heart blocks. And so those things are things that are going to occur potentially with age. It doesn't mean that everybody that ages has this happen, but these are things that occur with age. So yes, we're going to see decreased elasticity. Yes, we potentially are going to see the heart valves become thick and stiff, but not everybody that has that's going to develop a murmur. So these are generalized age changes. Other age-related changes that occur is the blood vessels, they get thick and less elastic. That's going to increase that systolic blood pressure. Remember, that's that blood pressure at the top. And you're not necessarily going to see much of a change in that diastolic, which is that bottom number. The patient may have what we call orthostatic hypotension, and that may really, what orthostatic hypertension affects is the patient's ability when they move not to potentially get dizzy, and that when they get up too fast and they feel dizzy, that blood pressure falls. That increases the risk for falls. And postprandial hypotension, that is when the blood pressure decreases after eating, again associated with falls. We also see what's called kyphosis, which is a musculoskeletal change in our patient. All of these things are potential things that can affect the overall health of our patient's cardiovascular system and put them at risk for complications. As we're doing our assessment, we are going to do a careful health history and physical assessment so that we can understand that if there's any cardiovascular problems present, we can distinguish those from problems with other body systems. So subjective data is data that the patient states. This is information the patient's going to tell us. So important health history. History that about their, what's happened in the past. History of any chest pain, diabetes, alcohol, tobacco use. Any other chronic illnesses such as anemia. Have they had any symptoms in the past for stroke or heart attack? We also want to know about present illness. So do they have chest pain now? Or do they get short of air? Do they have a cough? Do they have nocturia? Are they getting up in the middle of the night to go to the bathroom? We want to know about their cardiac history. We want to know about their family history. We want to know about any medications they're currently taking, their current and past use of medications. We want to know if they're using any over-the-counter medication. So it's extremely important that we get a complete list. And then we also want to know about surgery or other treatments. Part of our questions could include functional health patterns because there is a strong correlation between lifestyle and cardiovascular health. So that might include, do you exercise? How often do you exercise? We want to ask questions about smoking. Do you smoke? What do you eat daily? How often do you go to the bathroom? We want to know about urination and bowel movements. We also want to talk about their health perception. What does it mean to be sick? What does it mean to be healthy? We're interested to know what that means to your specific patient. Part of this could also include a sleep-rest pattern. Are they sleeping well? Do they have any problems at night? Are they short of air at night? What about their stress? Stress can play a part in the cardiovascular health as well. What are some coping mechanisms that they have? Anytime that we have a patient that has chest pain, this is part of our subjective data. We want to know, do they have any chest pain or tightness? We have to be very careful not to give the patient the answers to the test, so to speak. That means we want them to talk to us. We ask them about their chest pain. Can you tell us, when did it start and where does it hurt? We want them to describe it to us. If we tell them, is it sharp, stabbing, dull, achy, heavy, they're going to say all of those, right? So we want to make sure to be very careful in asking, can you tell me, can you describe it to me? Can tell me what it feels like? Because that's going to give us an overall idea of how they're feeling. So that's going to be important. What were you doing before the chest pain started? That's your precipitating events. So we need to know about that. What were you doing? Did anything make it better? Did anything make it worse? And did you take any medication for it? Did that medication help, or did it make it worse? What do you usually do have you had chest pain in the past, and what do you usually do when you have chest pain? The same type of thing will occur with when we have patients that have dyspnea, which is shortness of air, and cough. We want to ask them about the activity and when it occurs. When did it start? How long did it last? What were you doing? What position were you in? Is there a position that helps it? How does that affect your overall activities of daily living? Are you able to dress yourself, to bathe yourself? Does anyone help you? Do you live alone? What does your support system look like? If they have a cough, are you coughing anything up? If so, describe it to me. Those are things we need to know because we're going to be documenting all of that information. So the more detail that they can provide, the better, that we have a clear picture. And so we need to know all of that information. Additional questions that we can ask the patient about their history. We can ask them if they've had any swelling, which we could also call edema. Have they had edema, and where is it located? When is it present? How long does it last? And then what makes it better? Does it consistently stay, or does it go better if they sit down, if they elevate their feet? We can ask them if they have any orthopnea. This is shortness of breath that occurs when they lay flat. We can ask about nocturia. That happens when the patient gets up to urinate during the night. Also, any type of cyanosis or pallor. And that's ultimately just changes of the skin color. Cyanosis is a bluish gray color of the skin, the nails, or the lips. That can let us know that the patient's not getting enough oxygen. Pallor is simply very pale, kind of could be a gray ashen color, depending on the person's color of skin. But these are things that we want to know about. Have they experienced those, or are they experiencing those now? And then finally, we want to know about their past cardiac history. Have they had any diagnosis like high blood pressure, coronary artery disease, atherosclerosis? Have they ever had a heart attack? Have they had any type of surgical history? What type of diagnostic testing or imaging have they had done? Family history. Look at their family and their parents, siblings. Is there any type of cardiac problems that run in their family? Has someone died in their immediate family at an early age due to cardiac related disease? And then we want to know about lifestyle type information. How do you eat? What do you smoke? Do you drink alcohol? Exercise? What medications do you take? I think we've mentioned those before, but those are very important as we determine potential interventions going forward. Then we have our special populations. We have our infants. So we want to know about the maternal health. How was the mother's health during pregnancy? How was the birth? Was the baby healthy? Was there any problems? Are they eating okay? Do they have any color changes during nursing or when they're crying? Are they meeting all their developmental outcomes? And then with children, the same type of questions. We're asking the parents, are they meeting those developmental outcomes? Is there any concerns the parents have? How are they with activity? Are they complaining of any type of pain? Is there a cough? Do they get tired easily? Is there a history of respiratory infections? This could be upper respiratory infections. This could be RSV. How are they sick frequently? And then, what is that? How long does that illness stay present? And then looking at their family history, what does that genetics look like? Is there anything significant that we need to know? And then for pregnant women, we want to know, did they experience high blood pressure or hypertension during pregnancy? Did they have protein in their urine? How much weight did they gain? Did they experience swelling or edema? Do they have any symptoms of being faint or dizzy? A lot of pregnant women will, have symptoms that's just associated with pregnancy, but we want to know how extreme, how often did these symptoms happen, and what did you do about it? Did you go to the doctor? Did they relieve on their own? And clinically, was anything done? For our aging adult or geriatric patient, our focus is going to be on medication history. We really want to know what medications they're taking, prescription and over the counter. Our older patients fall into what's called polypharmacy, where they have multiple medications that they're on, and they're going to multiple different doctors and being prescribed all these different medications, and they don't necessarily know when and how to take them, and so they have a lot of side effects and potential for interactions. And so we want to make sure that we do everything we can as part of our assessment to get a really good and accurate medication list. And then if there's any education that we can provide on how and when to take the medications or expected side effects, then we can do that at that time. And then we need to know, are they compliant with their medications? Or, do they take them as scheduled, as they're supposed to? We also want to know what pharmacy they use in case we need to call and ask questions. The other thing is, how do they do their activities of daily living? So what's that environment look like for them? Do they need help? Are they able to get dressed every day? Are they able to shower, do basic hygiene, or do they need help? Do they live alone? Does someone live there with them? What does that look like? Is their environment safe for what they need, or is it, do they have hazards? A lot of times we'll have case managers that'll be present that we can talk to, or even can, help us, assist us with asking and finding this information out, maybe even sending someone to check the home if we're potentially concerned about their living environment. But we really want to know about that functional assessment and how they function on a daily basis. As we prepare to collect objective data, part of that's going to be our physical assessment. We're going to be putting the patient in different positions as we assess different parts of the body. We want to make sure that, especially for patients that are older or patients that have comorbidities that may not allow extra movement, that we go slow and that we try to do as many things in one position as we can so that we're not moving the patient around frequently. As we start to prepare, there's equipment we need to make sure that we have. We want to have our stethoscope. We want to have alcohol wipes to clean those earpieces. We want to make sure that we provide for privacy and make sure that we explain to the patient what we're doing. So we want to start out by looking at, doing some palpation and auscultation. As we go along, we'll be inspecting as well. So we'll be inspecting the skin. We're looking at the color, hair distribution, looking at our extremities for any type of edema, any clubbing of the nail beds, edema in the legs will be things that caused by different complications, such as right-sided heart failure. When we do our inspection, we will also be looking at the large neck veins, our internal and external jugular. We will be gradually moving the patient from the supine position to an upright position, about 30 to 45 degrees as we do that, just so that we can see if there's any prominent pulsations of the neck veins that would indicate some type of distension. We can palpate the pulses of the neck and the extremities. We'll palpate each carotid pulse separately to avoid any type of vagal stimulation and arrhythmias. We'll compare the characteristics of the arteries in the right and the left to determine symmetry. And then when we auscultate, this means we're listening. As we auscultate, remember that an artery that is narrowed or has a bulging wall may create a turbulent blood flow. So this abnormal blood flow will cause a buzzing or a humming sound that's termed a bruit. You'll be able to hear that best with the bell of the stethoscope over the vessel. We'll auscultate the carotid arteries, the abdominal aorta, and the femoral arteries as part of our initial cardiovascular assessment. This is a depiction of our neck vessels that just gives you an idea of where things are located as we are doing our assessment. These are things, of course, that you're not able to see on the external part of the body, but these are the things that we're listening for when we're auscultating, and then what we're feeling for when we're doing our palpation. So now you're gonna inspect and palpate the thorax. You kind of begin your exam by a general inspection. You're looking at what's called a precordium, and this is the portion of the body over the heart and the lower chest. So you're just going to inspect, just looking for any pulsations. You could palpate the areas where the heart valves project their sounds. You find your intercostal spaces to make sure that you feel these heart valves. Your aortic area is in the second intercostal space to the right of the sternum. Your pulmonic area is the second intercostal space to the left of the sternum. The tricuspid area is in the fifth left intercostal space close to the sternum, and the mitral area is the left midclavicular line at the fifth intercostal space. A fifth oscillatory area is what we call the Erb point. That's capital E-R-B. And that's located at the third left intercostal space near the sternum. Normally we can't feel pulsations in this area unless the patient has a thin chest wall. If they have a heart valve disorder, it may be present if you feel an abnormal pulsation or thrill. You're going to auscultate in the areas that we mentioned. Normal heart sounds are made by movement of the blood through the heart valves, so we can hear these sounds when we place the stethoscope on the chest wall. The first heart sound, the S1, represents closure of the tricuspid and mitral valve. It has a soft lub sound. The second heart sound, S2, represents closure of the aortic and pulmonic valve. It has a sharp dub sound. So if you've ever heard someone describe a heart sound as lub dub, so that would be what you would hear when you listen. So that's the second heart sound, and then you're going to listen for those. So S1 and S2 are heard best with the diaphragm of the stethoscope because they are high pitched. Your extra heart sounds, your S3 and S4, if they're present, they're heard best with the bell of the stethoscope because they're low pitched. So the diaphragm of the stethoscope, that's the larger part. You can hear high-pitched noises better with the diaphragm, and you can hear low-pitched noises better with the bell of the stethoscope, which is the smaller portion, the smaller side of your stethoscope. You can have your patient lean forward while setting to enhance the sounds from the second intercostal space. This is your aortic and pulmonic areas. And then you can place the patient in a left side lean position to enhance the sounds at the mitral area. Those will help you to hear those sounds. And then you're also going to be listening for murmurs. And remember we said murmurs, they're going to have a specific sound, and so you may be able to hear it. It may be loud, or it may be barely audible, so you may not be able to hear it at all. And murmurs are graded based on how loud they are, and so that, of course, isn't something we're going to determine, but it is something the doctor will determine. We will record the characteristics of any abnormal sounds, so that's going to include the timing. So that means when does it happen, during systole or diastole, the location that we heard it, so the anatomic site on the chest where it's heard the loudest, and then the position. Is it heard best when the patient is supine, setting, leaning forward, or in the left side laying position? And then we would note any other findings. Did they have an irregular apical pulse? Did they have a palpable chest wall heave? Or anything else that was associated with that sound? Remember, we document everything that we hear, that we look, listen, and feel, right? It's important that we document very thoroughly. And here's a good diagram or a picture of what we said when we said we were going to listen to each one of these different areas and where we're listening. And it also has the Erb's point, so that you're able to pick that out as well. And so you can practice with your stethoscope, either on a classmate or a family member. Heart failure is one of the most common problems you'll see in a clinical setting, and this is a clinical picture. So this is what your patient may look like if they have heart failure. And as you can see, it affects very multiple parts of the body, multiple organ systems. This is a patient who is probably struggling to breathe. They are, if you can notice in the stomach, their stomach is distended as they have extra fluid in that peritoneal cavity. They have what we call jugular vein distension because of extra volume. Then they may have extra heart sounds. So this is just a clinical picture of that patient in heart failure. And so and you'll learn more about the specific disease as you move forward with your different med-surg classes. But just depending on if it's left or right, and focusing on those potential complications based on where the problem is within the heart, you'll learn more about that. But this just kind of pieces together your assessment and why it's important that we do a thorough assessment and make sure that we get all of that information together. As you do your inspection and your auscultation and your palpation, you're going to be looking for abnormal findings. There's definitions here on this page that's called a thrill and a heave. So as you're inspecting the precordium or the thorax, the chest, right, you're going to be looking for heaves. Heaves are sustained lifts of the chest wall in the precordial area that you can see or palpate. And so you may be able to just lay your hand flat on the chest and physically feel a lift. Physically feel that hand go up. This could be because of a left ventricular hypertrophy, which is basically enlargement of that left ventricle of the heart. You also may feel or auscultate what we call a thrill. And remember, we had talked about the thrill as being like turbulent blood flow, something that you may be able to hear. So either of those are abnormal. If you have, in the apex is the top of the heart, so if you hear any type of extra sound, if you hear any type of murmur, if you hear, and we talked about some of those abnormal assessment findings, that could indicate that you have some extra volume or extra pressure at those sites. It could be caused from valve disorders, pericarditis. It could be from heart failure, volume overload. So a lot of different complications that we can find during our assessment, which is why our assessment is so important. And learning how to find the normal and the abnormal. There are multiple abnormal findings that you may hear or find because of different defects in the valves. Some of those may be when we hear those extra heart sounds. Some patients may have an extra heart sound that's completely normal, and that doesn't mean a problem. Having an S3 heart sound could also indicate left-sided heart failure or mitral valve regurgitation. It could also, we know that an S3 in some patients, especially our elderly, is called a ventricular gallop. For our S4, that extra heart sound, it's a low frequency vibration that's usually caused by some type of atrial contraction. It comes before the S1 and the next cardiac cycle, and we call it an atrial gallop. It may be normal in our older patients, but it could also mean coronary artery disease, cardiomyopathy, left ventricular hypertrophy, which is again that swelling of that heart muscle, or aortic stenosis. And then we talked about our different types of murmurs and the fact that could, having a murmur could indicate a problem. It doesn't always. Some people have murmurs and never have any type of issue, just depending on what it does to that specific patient. Everyone is individual, and we have to make sure that we definitely treat them that way. But when we hear any type of extra heart sounds or any heart murmurs, remember that they are caused, they potentially could be caused by some type of complication. So we always want to document and let our physician know. This is just a simple summary of the things we went over when we look at our neck and precordium. The things we're going to check are different pulses, carotid pulse, our jugular vein. We're going to be inspecting and palpating the chest wall, looking at our apical pulse, noting if we have any heaves or thrills. We're also going to be auscultating our different areas where our valves open and close, listening for any potential murmurs. And then remember the different parts of your stethoscope, right? The bell is for low pitch sounds. The diaphragm, we're going to listen for the high pitch sounds. There are three major types of blood vessels in our body. We have arteries, veins, and capillaries. Arteries, except for our pulmonary artery, carry oxygenated blood away from the heart. Veins, except for the pulmonary veins, carry deoxygenated blood toward the heart. And then we have small branches of our artery and veins that are called arterioles and venules. And so they're smaller, they're small portions of the arteries and the veins. The blood circulates from the left side of the heart into the arteries, the arterioles, the capillaries, the venules, then the veins, and then back to the right side of the heart. So when we talk about our arterioles, the arterial system differs from the venous system by the amount and type of tissue that make up our arterial walls. So the large arteries have thick walls, and they're composed mainly of elastic tissue. This elastic property cushions the impact of pressure from the ventricular contraction and provides recoil that propels blood forward into circulation. The large arteries contain some smooth muscles. Examples of large arteries are the aorta and our femoral artery, also our pulmonary artery. Then we have our arterioles. They have more smooth muscle and little elastic tissue. Our arterioles control arterial blood pressure and distribution of the blood flow. They respond readily to local conditions such as low oxygen and increasing levels of carbon dioxide by dilating or constricting. So peripheral artery disease affects non-coronary vessels and refers to arteries affecting the limbs. You can see these are the arteries in the arm. And you can see that it's listed here on the screen where we check our pulse. So remember, arteries have oxygenated blood. So if you or a patient were to stick an artery, you're going to have a lot more bleeding because it's under a lot more pressure than if you stuck a vein, or if the patient had, lacerated or stuck a vein. And then these are our vessels in our leg, and you can see the red is our arteries and the blue are our veins. So red, oxygenated, blue is deoxygenated. So we have our veins and our venules. So our venules are small vessels that have a very small amount of muscle and connective tissue. They collect blood from the capillary beds and channel it to the larger veins. Veins have a large diameter. They're thin-walled vessels that return blood to the right atrium. The venous system is under low pressure and high volume. Larger veins have semilunar valves at intervals to maintain the blood flow toward the heart and to prevent the backflow. Several factors affect the amount of blood in the venous system. This includes arterial flow, compression of the veins by skeletal muscle, changes in the thoracic and abdominal pressures, and then the right arterial pressure. The largest veins are the superior vena cava, which returns the blood to the heart from the head, the neck, arms, and then the inferior vena cava, which returns blood to the heart from the lower part of the body. Pressure on the right side of the heart affects these large vessels. And like we said previously, when we have venous flow, it's a very low pressure, high volume system. The lymphatic system is a different system that's completely separate than the vessel system. It retrieves excess fluid and plasma proteins from the interstitial spaces, and it returns them to the bloodstream. Fluid moves according to the pressure gradient, and we call this filtration. At the arterial end of hydrostatic pressure it's caused by the pumping action of the heart, and it pushes somewhat more fluid out of the capillaries than the venules can absorb. This fluid is vacuumed out of the interstitial space by the lymph vessels. Without lymphatic drainage, fluid would build up in the interstitial spaces and produce edema. So we have our right lymphatic duct that empties into the right subclavian vein. It drains the right side of the head, the neck, the right arm, the right side of the thorax, the right lung, pleura, the right side of the heart, and the right upper section of the liver. The thoracic duct drains the rest of the body. It empties into the left subclavian vein. The lymphatic system functions to conserve fluid and plasma proteins that leak out of the capillaries, that form a major part of the immune system that defends the bodies against disease and absorbs lipids from the small intestine. The immune system it's a complicated network of organs and cells that work together to protect the body. The lymphatic vessels, they do have a unique structure. The lymphatic capillaries are open-ended tubes that siphon interstitial fluid. Then they converge to form vessels and drain into larger ones. The vessels have valves, and therefore the flow is one way from the tissue spaces into the bloodstream. The many valves make the vessels look beaded. The flow of lymph is slow compared with that of blood. Lymph flow is propelled by contraction of the skeletal muscle, by pressure changes secondary to breathing, and by contraction of the vessel walls. Then we have lymph nodes that are small oval clumps of lymphatic tissue that are located at intervals along the vessel. Most nodes are arranged in groups. They filter the fluid before it's returned to the bloodstream. They filter out microorganisms that could be harmful to the body. And the pathogens are exposed to B and T lymphocytes in the lymph nodes. These mount an antigen-specific response to eliminate pathogens. With local inflammation, the nodes in that area begin become swollen and tender. Other organs related to the lymphatic system include the spleen, the tonsils, and the thymus. The spleen is located in the left upper quadrant of the abdomen. It has 4 functions. It destroys old red blood cells, produces antibodies, stores red blood cells, and filters microorganisms from the blood. The tonsils are located at the entrance to the respiratory and gastrointestinal tracts and respond to local inflammation. So we know that tonsils are in the back of our throat. The thymus is the flat, pink-gray gland located in the superior mediastinum behind the sternum and in front of the aorta. It's relatively large in the fetus and in young children, and it atrophies after puberty. It's important in developing the T lymphocytes of the immune system in children. The lymphatic system has the same function in children as in adults. Lymphoid tissue is well developed at birth and grows rapidly until age 10 or 11. By 6 years of age, the lymph node tissue reaches adult size. Lymph nodes are relatively large in children. With infection, excessive swelling, and hyperplasia, they can get larger. Enlarged tonsils are a familiar sign in respiratory infections, also in things like strep throat. In pregnancy, hormonal changes cause vasodilation, which opens up our vessels. This results in a drop in our blood pressure, and so that can be dangerous for the pregnant woman. The growing uterus obstructs the drainage of the iliac veins and the inferior vena cava, and this condition causes low blood flow and increased venous pressure. This can cause dependent edema, varicose veins in the legs, and hemorrhoids. And then as we look at our older adults, our peripheral arteries grow more rigid with age. This is termed arteriosclerosis, and this produces a rise in our systolic blood pressure. Now, don't confuse this with atherosclerosis, or the deposit of fatty plaques on our arteries. So we're talking about arteriosclerosis in this process. Both processes are present in peripheral artery disease in aging adults. Peripheral arterial disease is underdiagnosed and undertreated, yet it is a large cause of morbidity, painful walking, poor wound healing, and amputations. So some of those comorbidities we know that our patients have. Aging produces a progressive enlargement of the intramuscular calf veins, prolonged bed rest, prolonged immobilization, and chronic diseases like heart failure, chronic kidney disease, cancer, liver disease increase the risk for what we call DVTs, or deep vein thrombosis, which is basically a blood clot in the vein of the leg, and then subsequently that clot can move and cause a pulmonary embolism, so a clot in the lung. These conditions are common with aging. They can also cause a myocardial infarction. The loss of lymphatic tissue can lead to fewer numbers of lymph nodes in older people and a decrease in the size of the remaining nodes. The American Heart Association considers peripheral artery disease and coronary artery disease risk equivalent. Thus, we see screening and treatment for both. There is no single easily measured biomarker for peripheral vascular or peripheral arterial disease, so research is ongoing. We know that there is a role of smoking and thrombosis that goes up with any type of arterial disease, whether it's coronary or peripheral. So we want our patients to stop smoking. So we need to highlight the importance of smoking cessations. Also, other cardiovascular risks are like our high blood pressure, elevated cholesterol, obesity. Those are also things that are going to increase that risk for peripheral artery disease. African Americans have twice the prevalence of peripheral artery disease compared with non-Hispanic white persons, even after we adjust the traditional risk factors, and they are less likely to receive preventative care, timely diagnosis, and appropriate treatment, so they have a higher risk of severe disease. So due to these health disparities, remember disparities is a great difference. The healthcare team really needs to provide comprehensive screening for our African American population, for women and all aging patients, because they are the ones that are at increased risk, and then they do have the disparities in care. That could be lack of access, lack of knowledge, or knowledge deficit. So it's our job as healthcare workers to provide that education. Remember, collecting subjective data is simply asking the patient about their symptoms. Peripheral vascular disease includes peripheral artery disease and venous disease. With peripheral artery disease, blood flow cannot match muscle demand during exercise. That's why people feel muscle fatigue or pain when walking. They could have what's called claudication. Night leg pain is common in aging adults. It may indicate ischemic rest pain. Severe night muscle cramping, usually in the calf, or restless leg syndrome are also things that we potentially might see. So we're going to ask good questions like, do you have any leg pain or cramps? If so, where? Can you describe it for me? Is it aggravated by walking or any activity? Can you walk stairs? If so, does it produce pain? Has the amount of pain changed recently? Is it worse with elevation? Does it change with temperature? Does anything relieve the pain? We may also ask about any type of skin changes on the arms or the legs, any redness, pallor, blueness, brown discolorations, any changes in temperatures. We want to know about any swelling in the arms or legs. Edema is bilateral when caused by things like heart failure. It's unilateral when it's a result of a local obstruction or inflammation. We want to know about the swelling, if it comes and goes, what brings it on, what relieves it. We want to know, are they taking any medication? What's the medication that you take every day? And then we want to know about smoking. Do you smoke cigarettes? How many packs a day? What age did you start? Tobacco constricts arteries. It's the strongest risk factor for peripheral artery disease. As we ask patients to describe their pain, we're going to ask them about the onset and then does it have any impact on their activities of daily living. That's going to be important, especially with our older patients, because we need to know, do you need help with your activities of daily living? Is this something that you're doing on your own? Do you live by yourself? Do you have someone at home to help you? Has there been any recent change in exercise, a new exercise, or something that you've done differently? And then we also want to know a history about comorbidities. Do you have any other chronic illnesses or anything that we need to know about? Skin changes is going to be important because coolness occurs with peripheral artery disease. We also see what's called varicose veins. We want these patients to avoid compression stockings with peripheral artery disease because they do impede blood flow. They may be indicated to prevent leg swelling when people stand for long periods of time or for thrombus formation. But it's going to be important that we ask about color and temperature. And do they have those leg veins that look like varicose veins? And have they done anything to treat those in the past? Did they wear support hose? Do they have any leg sores or ulcers? Leg ulcers occur with chronic arterial and venous disease. So it's going to have a decrease in oxygenation. So it'll have that wound or ulcer will have trouble with healing. Large lymph nodes can occur with infection, malignancies, and certain immunological diseases. We want to ask the patient if they have any swollen glands, lumps or bumps under the skin, where in the body, how long have they been there, is there any recent change in them, did they feel soft or hard, and are the swollen glands associated with anything specific, like pain or local infection. And then, of course, like we said before, we're always going to get a clear medication history and ask about smoking. As we prepare to collect objective data, we're going to get our equipment. Sometimes we might need a tourniquet or a blood pressure cuff, a stethoscope. We may need a Doppler ultrasound if we think we're going to have trouble finding pulses on our patient. And sometimes the patient's pulses may be decreased if they have peripheral vascular disease. As we start our assessment, we're going to lift the person's hand in our hands. We're going to inspect, and then we're going to turn their hands over, looking at the color of their skin and nail bed. We're going to look at the temperature, the texture, and the turgor. We're going to see if there is any lesions, edema, or clubbing. You can use what we call the profile sign, which is viewing the finger from the side to detect early clubbing. Flattening of angle and clubbing occur with congenital cyanotic heart disease and what we call cor pulmonale. The normal nail bed angle is 160 degrees. With the person's hand near the level of his or her heart, we want to check capillary refill. This is an index of peripheral perfusion and cardiac output. We depress and blanch the nail beds. We release and note the time for color return. Usually the vessels will refill within a fraction of a second. Consider it normal if the color returns in less than 1 to 2 seconds. Refill lasting longer than 1 to 2 seconds may signify vasoconstriction or decreased cardiac output. The hands may be cold, clammy, and pale, which could also indicate a complication. We're going to check radial pulses. We want to note the rate, the rhythm, the elasticity of the vessel wall, and the force. Normal would be 2+. Full bounding pulse could happen with exercise, anxiety, fever, anemia. A weak 30 pulse, which would be 1+ or less, would occur with shock or peripheral artery disease. The modified Allen test is used to evaluate the adequacy of collateral circulation before cannulating the radial artery. Firmly occlude both the ulnar and radial arteries of the hand while the person makes a fist several times. This causes the hand to blanch. And then you ask the person to open the hand without hyperextending it. Then you release pressure on the ulnar artery while maintaining pressure on the radial artery. Adequate circulation is suggested by a palmar blush, a return to normal color of the hand in less than 7 seconds. Although this test is simple and useful, it is subject to error. We want to make sure that we cover the patient for privacy. So when we inspect both of the legs, we're going to look at them together, noting skin color, hair distribution, venous pattern, size, any skin lesions or ulcers. Pallor happens with vasoconstriction, or erythema happens with vasodilation. We want to just look to see if there's any type of edema. Both legs should be symmetric in size without any swelling. We want to measure at the widest point, taking care to measure the other leg in exactly the same place. And then we're going to palpate for temperature along the legs and down to the feet, comparing symmetric spots. The skin should be warm and equal bilaterally. Bilateral cold feet may be caused by environmental factors such as cool room temperature, anxiety, or cigarette smoking. If an increase in temperature is present higher up in the leg, note if it's gradual or abrupt. We also want to check for calf pain. We locate the femoral artery just below the inguinal ligament, halfway between the pubis and the anterior superior iliac spines. To help expose the femoral artery, particularly in obese people, ask the person to bend his or her knee on the side in a frog-like position. Press firmly, then slowly release, noting the pulse tap under your fingertips. If the pulse is weak or diminished, auscultate the site for a bruit. The popliteal pulse is more of a diffuse pulse and can be difficult to localize. This is behind the knee. With the leg extended but relaxed, you're going to anchor your thumb on the knee and curl your fingers around into the popliteal fossa. You press your fingers forward, hard to compress the artery against the bone, and often this is the most difficult to palpate in adults. Your posterior tibial pulse, you're going to curve your fingers around the medial malleolus. Press softly, and you'll feel the tapping right behind it in the groove between the malleolus and the Achilles tendon. If you cannot, try passive dorsiflexion of the foot to make the pulse more accessible. So this is going to be near your ankle. And then dorsalis pedis, this is requires very light touch. It's right on the top of your foot. Normally it's just lateral to and parallel with the extensor tendon of the big toe. Be careful not to mistake the pulse in your own fingertips for the person. In older adults, or adults older than 45, occasionally the dorsalis pedis or the posterior tibial may be hard to find, but not both on the same foot. So you should be able to feel one or the other. Checking for pretibial edema, you firmly depress the skin over the tibia or the medial malleolus for 5 seconds and you release. Normally your fingers should leave no indentations, although a pit commonly is seen in persons that has been standing all day or people that are pregnant. Bilateral dependent pitting edema occurs with heart failure, diabetic neuropathy, and hepatic cirrhosis. If pitting edema is present, grade it on the following scale. 1+, mild pitting, slight indentation, no perceptible swelling of the leg. 2+, moderate pitting, indentation subsides rapidly. 3+, deep pitting, indentation remains for a short time and leg looks swollen. 4+, very deep pitting, indentation lasts for a long time and the leg is grossly swollen and distorted. Unilateral edema occurs with occlusion of a deep vein. Unilateral or bilateral edema occurs with lymphatic obstruction. With lymphatic obstruction, it is brawny or non-pitting and it feels hard to touch. If you suspect an arterial deficit, raise the legs about 30 centimeters or 12 inches off the table and ask the person to wag the feet for about 30 seconds to drain off venous blood. The skin color now reflects only the contribution of arterial blood. A light-skinned person's feet normally look a little pale but should still be pink. A dark-skinned person's sole should reveal extreme color change. Elevational pallor marked indicates arterial insufficiency. After that, you would want to test the lower legs for strength and sensation. To use the Doppler ultrasound, this is used to detect a weak peripheral pulse or to monitor blood pressure in infants or children, or to measure a low blood pressure or blood pressure in a lower extremity. The Doppler probe magnifies pulsatile sounds from the heart and blood vessels. You would position the person supine with the legs externally rotated so you can reach the medial ankles easily. You would place a drop of coupling gel at the end of the handheld transducer. Then place the transducer over a pulse site at a 45 to 60 degree angle, pointed slightly towards the direction of the blood flow. Apply very light pressure and tilt the probe around until you locate a swishing, whooshing sound of the pulse. The ankle brachial index. The use of a Doppler stethoscope is a highly specific, non-invasive, and readily available way to determine the extent of peripheral arterial disease. The patient lying flat with the head of the bed and heels feeling supported. Confirm no smoking with 2 hours of the measurement and allow a 5 to 10 minute rest period supine before measurement. Choose the correct cuff width for the arm and the ankle. The width should be about 40% of the limb circumference. Position the ankle cuff just above the malleoli with straight wrapping. An ill-fitting blood pressure cuff could produce a false high arm blood pressure and therefore a false low ankle brachial index. It could prompt unnecessary worry and invasive testing. There's a specific formula that's listed on 522 of your book. This again, you don't necessarily need to memorize. This is something the physician will do. You just need to know that it exists. The Wells score for deep vein thrombosis is it's used for deep vein thrombosis. There's specific criteria that you have to use, and you can see on the screen, the higher the score, the greater the risk. DVT present with unilateral swelling of the affected leg, tenderness to severe pain, possible warmth and redness from accompanying inflammation, and possible superficial venous dilation. We evaluate the symptoms considering the patient's history and current medical condition. In infants and children, you'll learn more about this when you study pediatrics, but the pulse force should be normal and symmetrical. It should be the same in the upper and lower extremities. Weak pulses occur with vasoconstriction, which diminishes cardiac output. Full bounding pulses occur with patent ductus arteriosus from the large left to right shunt. Diminished or absent femoral pulses, but normal upper extremity pulses suggest coarctation of the aorta. And those are just some abnormal findings. Of course, they're also emergent. So if we see something abnormal, especially in our young children, we want to make sure that we notify our physician right away. Palpable lymph nodes often occur in healthy infants and children. They are small, firm, mobile, and non-tender. Vaccinations can also produce local lymphadenopathy. You want to make sure that you note characteristics of any palpable nodes and whether they're local or generalized. In pregnant women, expect diffuse bilateral pitting edema in the lower extremities, especially at the end of the day and into the third trimester. Most pregnant women will have peripheral edema because of increased water retention. Varicose veins in the legs are also common during the third trimester. You want to make sure to remain alert for generalized edema plus hypertension. This could suggest preeclampsia, which is a dangerous obstetric condition. And then for our aging adult, you may have some pulses that may become more difficult to find. You may also have some changes that are associated with arterial insufficiency, like thin, shiny skin, thick, rigid nails, loss of hair on the lower legs. These are all things that occur normally with aging. So good teaching points for your patients. You want to make sure that teach them about foot care. We often miss the kind of information and education about how important it is to take care of our feet. But good foot care can prevent serious problems later on. And in certain conditions like heart failure and diabetes, that can be very important to take care of our feet. So some things we want to make sure and let them know: to look for red spots, sensitive areas, cuts, blisters, and chrome toenails. Use a mirror to check the bottom of their feet daily, especially if they have diabetes, because that's important, because remember that any type of bacteria loves sugar. So if they have an open wound and they have uncontrolled diabetes, then they're going to develop a bacteria that's going to be difficult to get rid of in a wound. So they want to check their feet daily to ensure that they don't have any type of open wound, cracks, calluses, or anything like that. They should wash their feet regularly, especially between the toes, to make sure they dry after every time they wash them, and gently slide a towel between each toes. Keep toenails trimmed straight across and filed at the edges. Some facilities require a licensed person to be the one that trims toenails, especially for patients like diabetics. So make sure you check your facility protocol before you do any type of cutting on toenails. Wear clean socks every day. It's also important. We want to make sure that to keep the blood flowing to the feet, walking is a good way to do this. Some type of range of motion exercise. Wear shoes that fit and are comfortable. Wear them when you're outside. And then finally, keep the skin on your feet soft and smooth. The end of this chapter, the next few slides cover some abnormal findings. This slide talks about variation in what we call pulse contours. And ultimately, we're just talking about the differences in how we feel a pulse. When we say weak and thready, that might be something that's hard to palpate. We may need to search for it. It may fade in and out, and it might be easily obliterated with pressure. So if we press too hard, we may not be able to feel it at all. A full bounding pulse, that's easily palpable, and you feel it very good under your fingertips. A water hammer pulse, this is greater than normal force, and then it collapses suddenly. Then you have pulseless bigeminous. This is rhythm coupled. Every other beat comes early, or a normal beat followed by a premature beat. Force of premature beat decreased because of shortened cardiac filling time. This could indicate a PVC, like a premature ventricular contraction, some type of conduction disturbance. Pulseless alternates. This is rather regular rhythm, but the force varies with alternate beats of large and small amplitude. The next one is pulseless paradoxes. This is when the beats have weaker amplitude with inspiration, stronger with expiration, best determined during blood pressure measurement. The reading decreases by 10 millimeters during inspiration and increases with expiration. You may find this in complications like cardiac tamponade, or if you have patients that have severe bronchospasms and acute asthma. And then the last one, the pulseless biserphinous. Each pulse has two strong systolic peaks with a dip in between. This is best assessed at the carotid artery. You may have this with the patient that has aortic valve stenosis plus regurgitation. Abnormal findings in the arm may include Raynaud's phenomenon. This is where you may have some different colors in the fingers in response to cold, vibration, or stress. So you may have white in the top, so a little bit of white, or you may have some blue cyanotic color in the fingers, or you may have some red at the heel of the hand. They may have some cold or numbness or pain that come along with the changes in color. Avoidance of cold is the most effective therapy. You may have also something called lymphedema, where you have a chronic progressive accumulation of protein-rich fluid in the interstitial spaces that causes swelling. Oftentimes you might see this after breast cancer surgery or treatment. And then you may have some abnormal findings in the legs. So you may have some leg ulcers. These might differ based on if they're arterial or venous. For arterial ulcers, you might see coldness only in one foot or leg. You may have pallor. You may have elevational pallor when it's raised up. That's when it's going to change color. It may also have signs of malnutrition, like thin, shiny skin or thick, rigid nails. And then if you had a venous stasis ulcer, this could happen after an acute DVT or some type of chronic incompetent valve in the deep vein, so some type of circulatory compromise. You might see lower leg edema that doesn't get better after giving a patient a diuretic. You might see a thickened skin, some firm edema. The pulses might be normal. They might have some brown discoloration, and also might increase the venous pressure in that area. But you want to make sure that you do understand the difference between arterial ulcer versus venous ulcer, simply because that you're looking at two different processes. Okay, and so with a chronic venous disease versus acute venous disease, it's the same type of thing. Chronic venous disease, you have superficial varicose veins. Patient might have these dilated veins in the legs. You may see generalized leg swelling. For the acute venous disease, this is more like a deep vein thrombosis or some type of thrombus or clot that causes inflammation. So you have increased warmth, you have swelling, redness, and it's tender to palpation. And then we have peripheral artery disease. And basically two definitions that you'll want to know. Aneurysms. An aneurysm is a sac formed by dilation in the artery wall. Remember, atherosclerosis weakens the middle layer of the vessel wall. The most common site is the aorta, and the most common cause is atherosclerosis. And then you may have occlusions. Occlusions in the arteries are also caused by atherosclerosis, which is that chronic buildup of the fatty plaque, calcifications of that wall, and even thrombus formation. This reduces blood flow to all those vital areas, so your organs aren't getting enough oxygen and nutrients. This is a nice slide with some different videos that will help you to understand the abnormal findings. It's hard to understand what you're listening for if you've never heard it before. So definitely take time to click through these so that you can hear the different things we've talked about through these chapters, so that it'll make more sense for you.